Hi, everyone. Thanks for joining today. We're going to get started in just a couple minutes. All right. Tracy, would you like me to get started?
That sounds great. We have a lot to cover.
Great. Good afternoon, everyone, and welcome to the Leadership Development Group's webinar entitled The 2023 Healthcare Revolution. Will you be part of the solution or a cog in the wheel? Being presented by Dr. Kent Bottles and TLD Group President and Founder, Tracy Duberman. My name is Jessica Molson, Chief of Staff at the Leadership Development Group. Just a few quick notes before we get started. Please note that all attendees are automatically on mute for the duration of the webinar. We will be taking questions. Please feel free to submit your questions via the question box on your Zoom webinar control panel, and they will be presented to our panelists at the appropriate time. This webinar is being recorded, and we will provide a link to the recording to all attendees. We appreciate your attendance and hope that you find this webinar valuable. Ken, can you take me to the next slide?
Sure.
During today's webinar, we will cover the following learning areas: align on health industry's state of the state, review case studies of recent healthcare transformation efforts, and identify how leaders can drive meaningful change in 2023 and beyond. Next slide. Please note that our agenda today is intentionally designed to agitate, as Kent and Tracy take you on a journey into the current state of the US healthcare industry, cover ways in which the healthcare landscape is changing, and discuss important case studies from organizations attempting to revolutionize healthcare. At the end of today's presentation, we're going to tie it all together with leadership lessons learned and a path forward towards revolution driven by leadership and learning from the past. Without further ado, I'd like to introduce you to Dr. Kent Bottles. Dr. Bottles currently serves as a TLD Group Advisory Board member and has held a number of physician executive positions over the course of his career, including tenured professor at the University of Iowa and Michigan State University, College of Human Medicine, president and CEO for Clinical Systems Improvement in Minneapolis, president and CEO of the Grand Rapids Medical Education and Research Center in Michigan, among many others. We're excited to have Kent here today to share his perspective on the healthcare revolution. Kent, over to you.
Thanks so much, Jess, and it's an honor to be here. So will the healthcare revolution ever come? I have a confession to make at the beginning. I'm not sure there really will be a 2023 healthcare revolution, and that's part of what we need to address is how is it so hard to disrupt a dysfunctional healthcare delivery system? So for decades, we've been predicting that there'd be creative destruction of the healthcare system. Eric Topol has written several books about how technology is going to create creative destruction. So when will this healthcare revolution ever occur? I'm 70 years old, and for decades, I've been talking about how we probably will have a revolution in healthcare. And maybe as I get older and wiser, I'm starting to realize that there's a bunch of reasons why it's so hard to disrupt the dysfunctional system. And can we learn from failures to disrupt the system? And today we're going to talk about 3 case studies: Amazon, IBM Watson, and then the difficulty in transitioning from fee-for-service to value-based payments. So my prediction is that 2023 will be very uncertain. Clearly, the pandemic has revealed systematic problems in the healthcare delivery system. So we really can't just go back to how it was before the pandemic. We really need to fix the problems that the pandemic has revealed. And if we know anything about past pandemics, historically, they've been followed by unexpected changes that have really totally transformed economies and industries and actually global politics. So 2023 is going to be very uncertain. So although I agree with Trotsky that all revolutions are impossible until they happen, then they are inevitable. So it can be that a revolution will occur when there's finally a tipping point. It's just been that it's been really hard to find that tipping point in the past. I want to start out with some Commonwealth Fund charts just to remind us of how dysfunctional the American healthcare system really is. This was looking at healthcare system performance, comparing and contrasting Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the UK, and the US. And our overall ranking is last place. So of these 11 industrialized countries, the United States comes in last. And you can see that in every part, except for care process, in which we did pretty well, we came in last. We came in last in access to care. We came in last in administrative efficiency. We came in last in equity, and we came in last in healthcare outcomes. I think it's interesting that in care processes, we came in second. So we certainly know how to deliver evidence-based medicine. It's just that we don't do it in a very efficient or equitable way. This is the main graph, which tells you why healthcare is unsustainable. You can see the red line from 1980 to past 2015, that the United States healthcare spending as a percentage of GDP is really much higher than all of the other countries that we compare ourselves to. And it looks like right now we have about a $4 trillion healthcare spend, which is approaching 20% of GDP, which is just unsustainable. So why is it unsustainable? Well, if you care about anything except for healthcare, maybe national defense, or maybe education, or maybe the ecology, or anything else, if you're spending all this money on healthcare, you don't have money to spend on other things like education, defense, or the ecology, the climate change problems. So really, we spend a lot more money for the healthcare that we get, and we get last place performance quality. So that's not great. So you'd think that the healthcare system is ripe for revolution, ripe for transformation, and people have been talking about that for decades, but we don't seem to ever achieve it. So the first polling question, Jess, is shown on the slide.
Yes. So our first polling question is, what is the most important characteristic of countries with high-performing healthcare metrics? Is it A, providing universal coverage and removing healthcare barriers? B, investing in primary care systems to ensure that high-value services are equitable? C, reducing administrative burdens that divert time, efforts, and spending from health improvement efforts? Or D, investing in social services for children and working-age adults? Give everyone just a couple more seconds here to get in their answers. All right. Ken, are you able to see the results?
I am. So I think this is interesting. 58% said providing universal coverage. 21% said investing in primary care. 3% said in reducing administrative burdens. And only 18% said investing in social services for children and working age adults. I think that's interesting because if you go and look at the Commonwealth study, you can see that we came in last in terms of performance. And the four features that distinguish top performing countries from the United States are they do provide universal coverage and remove cost barriers. They invest in primary care. They reduce administrative burdens that divert time, efforts, and spending from healthcare improvement efforts. And they invest in social services, especially for children and working age adults. I think the last one is actually really, really important because we really don't invest in public health. We don't invest in social services compared to places like France or New Zealand or the UK. Well, one of the reasons why I think it's so difficult to achieve a healthcare revolution is that the healthcare landscape is not static. It keeps changing. And although I don't usually agree with Regina Hertzlinger about much of anything, I really like the 6 forces that can drive innovation or kill it. This is from an article that she wrote in Harvard Business Review. And one of the things she says is that one of the forces is players. And as we're going to see, the players in healthcare are changing immensely since I graduated from medical school in 1980. So you have friends and foes lurking in the healthcare system that can destroy or bolster an innovation's chance of success. Funding. We've really had a hard time transitioning from fee-for-service to value-based payments, and we'll talk about why that is. Policy. Certainly, there's gridlock at the federal level, and we have difficulty with regulations that pervade the industry. And one of the problems is the FDA has a real hard time and takes a long time to approve new technology. And that leads us to technology. Certainly, all of us are grappling with how AI and machine learning algorithms are going to change healthcare, perhaps replace some physicians. And then we have customers or consumers who are more and more engaged in healthcare. And some folks don't like the passive term patient. So these are all forces that can drive innovation or kill it. And I think we need to talk about all of them. One of the things that I think is really remarkable is the change in physician employment over my healthcare career. Between 2019 and 2022, there's been a 38% increase in the percentage of employed physicians. And right now in 2022, about half of all physicians are employed by hospital systems, 22% employed by corporate entities, and only 26% are still independent private practice physicians. This is a big, big change from when I entered healthcare in 1980, when about 70 to 80% of all physicians were independent. And it certainly was quite a different system when the independent private practice physicians were not employed by the healthcare system, but used the hospital as really their workplace and didn't really pay for it. And there's been big changes. One of the biggest changes is the difficulty in now engaging in independent physicians because they're no longer seen in the lunchroom and no longer come to meetings because now most of the physicians are employed. It's a big change that Optum and United Healthcare are the largest employer of physicians. They employ 53,000 physicians, followed by HCA with 45,000 physicians, and Kaiser Permanente, which employs about 24,000 physicians. So payers and providers or providers, United Healthcare and Optum's the biggest one. It's a multi-specialty clinic. It's $54 billion services. And Optum now is the main driver for profitability at United Healthcare. Clearly, the Aetna and CVS merger with their health hubs and CVS stores are really a big player, and United Healthcare and Walmart. So the strategy here is to drive health plan growth and performance and profit from value-based payments, if we ever get to value-based payments. Another thing that is quite different from most of my career in healthcare are the new primary care aggregators. Now, these are things like Oak Street Health, Iora Health, One Medical, and you can see several more here. The ones I'm most familiar with are Oak Street Health, Cana Health, Iora Health, and One Medical. Now these are quite different. These are actually Oak Street Health, as one example, has gone through an IPO, and it's a big company. Third quarter earnings were just reported, revenues of $545 million, but it had a net loss of $130 million. So why is it losing so much money? Because these primary care aggregators really only work if you have capitation, if you've already transitioned from fee-for-service to value-based payments. So Oak Street Health, as an example, really is looking at older patients or consumers. They have comprehensive prevention care. They have personalized wellness plans, and actually a lot of educational and social activities. They have care teams, and they have much longer appointment times than traditional primary care. So in these cases, these primary care aggregators acquire or employ the physicians. But there's another kind of interesting group of primary care, which are called aggregators. And they don't employ physicians, but they convene or aggregate physicians. The one I know the most about, and probably the best example, is Aledade. And Aledade has over 1,000 independent practices. Now, they're still independent private practices. And they've raised, in June of this year, they just raised $123 million in a Series E round. A Series E round is usually the fifth round of venture capital funding, and it's usually the one that's just before the entity has an IPO and goes on the stock market. So this company, this aggregator, provides data analytics to the independent private practice companies, practices, regulatory expertise, payer relationships, alternative expertise, and they try to make it simple for the private practice doctors who are still independent to join a local ACO and to be able to be successful in an ACO. They now have about 1.7 million patients in 40 states. And their big thing is to use care transitions to avoid readmissions. And they provide a lot of risk stratification information to the primary care aggregators. Then we get to investor-backed specialty deals. So these are private equity deals. And this is kind of interesting because this has really gone really crazy in the last few years. These private equity deals, the targets are things like multi-site providers. And there's many examples here in ophthalmology, in orthopedics, in dermatology, in GI, and also now in women's health and in urgent care and in home care. So these investor-backed specialty deals is really where there's so much pension fund money and growth and equity funds that they want to invest it in something. So companies like Bain, which you've probably heard about because Mitt Romney was a partner in Bain for several years, and his wealth is due to his private equity investments. So a private equity company would target something like GI practices. And you can see one example is GI Alliance. So there's a leveraged buyout, which they buy up the practices and try to increase the number of practices. The leveraged buyout is that the private equity firm doesn't really use its own capital. They raise capital from pension funds and equity, growth equity funds. They then restructure the acquired firm, emphasizing efficiency. So they usually keep the doctors, but they really, really use evidence-based medicine protocols. They use a lot of physician executives, and the back office functions of HR and of other functions are really, really made efficient, and all that matters is profits. They also load a lot of debt onto the acquired company, and there's large fees that flow to the private equity firms. And their whole idea is to increase the value of the acquired firm, and they sell it, it'll be sold within 3 to 5 years. Who do they sell it to? They usually sell it to another private equity firm or to a system. Now, many people have criticized this investor-backed specialty deals in healthcare. Why? Because healthcare is an essential product that we all need, and that basically these folks say that private equity does not improve access to care. It clearly contributes to higher Medicare and Medicaid costs, which are driving that 20% of GDP spent on healthcare that's unsustainable. These critics also say that private equity encourages less credentialed providers, and there's been some studies in dermatology to say the less credentialed providers, the PAs or advanced nurse practitioners, use more biopsies and increase the cost of care. And so basically, if you have a profit-driven system like this, the profit is more valuable than the patients, than the community, than the workers that work for the company, than the environment of the quality of services. And remember, there's been a number of cases outside healthcare where private equity has been used and has led to bankruptcy, such as Toys R Us, Gymboree, Necco, which makes candy, J. Crew, and Neiman Marcus. And some of these healthcare acquired systems have gone bankrupt. For example, Derm One went bankrupt in 2018 after acquiring 40 practices in 5 states. So this is really happening at a higher rate than in the past. And you can see on this slide that this is healthcare private equity deal activity. And you can see that it's not just multi-site providers. That's basically in the turquoise, but it's also biotech and pharma, med tech or health IT, healthcare services, and healthcare devices and suppliers. So a lot of private equity money is flowing in from 2011 to 2021. You can see an increase in deals. Recently, Bain, which Romney worked for, bought Athena Health last year, and it's valued in a $17 billion deal value. So private equity is kind of a new thing in healthcare and is really changing the landscape of care that's provided to patients. If you want to learn more about private equity, which is very interesting, Bain has on their website some really good information that's mostly positive about private equity in healthcare. And there's a book out from Johns Hopkins University Press called Ethically Challenged: Private Equity Storms into US Healthcare by Laura Katz-Olson, that takes a much more critical view of this. And if you're interested, in this week's New Yorker, there's a long piece that looks at private equity in hospice, and it's pretty devastating expose about some of the shortcomings of private equity in hospice. Now, there's vertically integrated retailers. We're all aware of Amazon and One Medical, of Walgreens and Village MD and Walmart. So these are the strategy here is to grow the retail business by leveraging the size, data, consumer reach, and breadth of resources to capture a share of the healthcare market. And these have really been quite interesting and quite competitive to traditional healthcare providers. A visit or a flu shot is much less expensive at a Target or a Walgreens or a Walmart clinic. This is a slide that came from Verilon, and I think this is really important because this summarizes all of the new impact of the new players in healthcare. On the left-hand side, you have the healthcare system we're all used to. The health systems, where I live, that would be University of Pennsylvania, Jefferson University, and Mainline Health. These are committed to geography, they're mission-driven, they have strong balance sheets, and they have a long-term commitment to healthcare. And they're employing many more physicians. The insurance companies like Optum have lots of money and lots of data. They're committed to healthcare. They're shareholder driven, and they're trying to meet growth goals by requiring continuous rethinking of their physician strategy. What I think is interesting and providing a lot of uncertainty to the healthcare market is what's over here on the right. And these are the vertically integrated corporate entities. That's the Walgreens and the Targets and the Amazon. So healthcare strategies are evolving. Growth is their ultimate goal. And they really don't have a long-term commitment to healthcare and to patient care. The new aggregators that we talked about, the Iora Health and the Oak Street Health, I think there's going to be a lot of consolidation here. Not all of them will survive. They need a path to profitability. All of them are losing money, and they're highly sensitive to changes in Medicare and Medicaid risk contracts. And then you have the investor-backed private equity firms, and these where it's clear they want to sell them in 3 to 5 years. The financial bottom line is the only bottom line, and the only certainty is what can be negotiated into the agreement. Although this is attractive for many older physicians to sell their practices, they're often promised that they'll be able to just practice medicine and not worry about the business side, but many of them have not been happy with the results. Patients are losing trust in providers. You can see here that in doctors, it's a decrease of 23%, in hospitals, 21%, and nurses, 16%. The CDC is down 14%. State and local public health officials down 13%. And health insurance companies that started at only 20% trust are down 5%. I would add to this slide that physicians are losing trust in healthcare. The number of physicians that feel burnt out from the COVID epidemic, the lack of the public being responsive to public health measures, many physicians are retiring early or leaving the practice of medicine entirely. So when will this healthcare revolution occur? Any company that says it's going to revolutionize healthcare by itself is really delusional. Only a minority of Americans are pushing for change. Only a minority of Americans are involved in healthcare on a daily basis. And obviously you have vested interests in the medical industrial complex. Whenever something comes up that might be helpful on a national basis, there's lobbyists that come in and really make it difficult for it to be passed for Medicare and Medicaid. Because what looks like a savings to you is taking away money from a group with a lot of lobbyists. So there's a difference between popular consumer products and healthcare. Who really wants to go to the doctor? Big tech alone cannot solve healthcare's problems. Why? It's very complex. There's a lot of inconsistent, siloed, and dirty healthcare data. You can't just put healthcare data into an algorithm and get a good result. Much of what has to be done is cleaning up the data so it can be put into the machine learning. And think about it. How many industrial specific terminologies there are, like ICD-10, SNOMED. The data is in disparate sources. It's totally unstructured data. And probably the biggest problem I've identified is the difficulty of communication between clinicians and computer engineers who have different cultures. They really talk past each other. And this is a recent article in the Wall Street Journal, which talked about twilight of the tech gods. For a while, it seemed like we all were looking to Silicon Valley and these brilliant CEOs that mastered electronics code and early stage investing that could transform any industry and make outsized returns. We were looking for who's going to be the Uber for healthcare. But now it looks like some of these CEOs have not been so successful. Elon Musk spent $44 billion on Twitter. As of today, the valuation of Twitter is $8 billion. Amazon and Meta are having large layoffs, and we've just had a crypto meltdown. So Americans' largest tech companies have recently lost $2 trillion in value on the stock market. This is a really important slide. One of the topics, and this slide comes from people that are looking at equity and how to make algorithms more fair, is this idea of decentering, that we move technology away from the center of attention and as the thing that we build to apply to people and toward the sides as a tool to help people. I can't tell you how many companies I've talked to that have a brand new technology solution, and that you see here in the middle. And this app or this solution is going to be the Uber of healthcare and is going to make investors billions of dollars. And it's going to create better healthcare for people on the outside here and for doctors. The problem is that these apps, again, computer engineers are brilliant, but they don't really understand the complexity of healthcare. And the problem is that we need to center what the problem is for people and then create apps and create technology to address problems that people have. This centering, I think, is really, really crucial to being able to utilize technology. So let's take a look at 3 attempts to revolutionize healthcare. Let's start with Amazon and Haven. Remember Haven? Haven was going to be the way that healthcare was going to be transformed. 3 of the biggest companies, most successful companies in America, Amazon, Berkshire Hathaway, and JP Morgan Chase, who were led at the time by legendary people, Jeff Bezos, Warren Buffett, and Diamond of JP Morgan Chase. Collectively, they had 1.2 million employees, and their mission statement was to provide US employees and their families with simplified, high-quality, transparent healthcare at a reasonable cost. And then they were going to utilize what they learned for the entire healthcare system. They hired superstars, Atal Gawande, you can see here on the left, who was a Harvard professor and wrote the article in the New Yorker that Obama used to convince the senators to pass the ACA. And Jack Stoddard, who many of you may not know, but he was hired as COO of Haven. He was a very successful manager of digital health at Comcast here in Philadelphia, where I live. Well, John Toussaint, who used to run ThedaCare in Wisconsin, wrote an article in the Harvard Business Review about why Haven failed. Really, even though they had over 1 million patients, had insufficient market power. You really need 50% of patients in any one market to be able to negotiate successfully. And their patients were spread out over the whole country. The consolidation of hospital systems has increased hospitals' power to charge higher prices. Really poor timing. The pandemic has providers not considering new ideas, perverse incentives, hospitals still get paid more if beds are full, and that we've had difficulty moving to value-based payments away from fee-for-service. So Amazon then, after Haven failed, here's an article from November 10th, 2019 by Christina Farr, who's now no longer a healthcare journalist, but has become a venture capitalist. Here's how Amazon employees get healthcare through a new app. It's a glimpse of the future of medicine. And in this article, it really talks about Amazon has solved the problem of how to disrupt healthcare. Well, in the same journal, this is from August 24th, 2022, Amazon is shutting down its telehealth service, Amazon Care. Amazon shuttering its telehealth service. Amazon was launched in 2019 as a pilot program for employees. It's unclear how much traction Amazon Care has gained. So Amazon's not giving up. As you probably know, that they've bought One Medical, which we mentioned was one of those aggregators. One Medical has a membership-based primary care provider. It's in 19 cities. It doesn't accept Medicaid, and it's really not profitable now, and it would need full capitation to become profitable. One pundit said, against most companies that sell products in America, Amazon is a Goliath. Put it up against the problems in the American healthcare system, and it looks like David with a slingshot made of wet spaghetti. The next attempt to revolutionize healthcare, remember, was IBM Watson. And who can forget how this made a big splash? IBM Watson was designed to win at Jeopardy, and it did. IBM then thought this was a moonshot. And anytime a CEO talks about moonshot, I think we should get skeptical. IBM invested over $5 billion acquiring large data sets from companies like Truven, Vitel, Explore, and Merge. And at one time, IBM Watson had over 7,000 employees. It had really high-profile partnerships with Memorial Sloan Kettering, MD Anderson, and University of North Carolina. These are really, really top-notch healthcare systems. And remember, on TV, there were advertisements for IBM Watson with Serena Williams being interviewed by IBM Watson, and even Bob Dylan. The problem was that David Ferrucci, who was the lead engineer in developing IBM Watson to win at Jeopardy, tried to warn his upper echelon C-suite that it was designed to win at Jeopardy, not to be an all-purpose answer box for medicine. The problem turned out to be that it didn't work very well. So again, MD Anderson announced with great fanfare that they were going to use IBM Watson cognitive computing system for its mission to eradicate cancer. It was a very unusual business arrangement that didn't work. MD Anderson paid IBM almost $40 million. They also paid PricewaterhouseCoopers $22 million for a business plan. Why they bypassed their own IT department is beyond me. And these payments were not linked to deliverables. So they had a lot of challenges. It didn't work. They had challenges integrating a new Epic EMR system. The data quality wasn't good enough for the algorithms. Data integration is hard and important. This is really important. You need a mechanism to regularly train and validate AI performance. Because it's a black box, you really don't know if it's going to be successful till you try it. They focused the project at MD Anderson from leukemia to lung cancer. But their biggest problem was the difficulty of communication between the oncologists, the computer engineers, and the business people. So why Watson failed was that the top leaders were salespeople and not product people, and they clearly overpromised and underdelivered. There was a 2017 internal IBM document that quoted a physician using a highly technical term that Watson was a, quote, a piece of shit, end of quote. The combination of a very difficult goal and an immature, untested technology was the downfall of IBM Watson. And right now, it's been reported that IBM has sold off IBM Watson for parts to what? To a private equity firm, Francisco Partners. And although IBM Watson was trying to get $1 billion for it, rumors are that it went for a lot less than that. So value-based care. We all know that we're trying to move from fee-for-service to value-based care, and it's very important that Medicare is really, really trying to push us in this in terms of macro and MIPS. So the first curve is fee-for-service. It's the way that healthcare has been funded forever. Quality is not rewarded. You pay for volume. If you have more patients in your hospital, you make more money. Fragmented care is tolerated. Acute hospitals do just fine, and standalone independent providers and physicians do just fine. To help us not spend 20% of our spend on healthcare, we want to go to the second curve, and that's value-based payments where continuity of care is required. You have to have systems of care, and you need a IT-centric to be able to do that. Providers are now at risk for payment. There's usually upside risk and downside risk, and you need a physician alignment to make this work. The problem is the transition. We're still in the middle of the transition from fee-for-service to value-based care, and most people still get most of their money from the first curve, from fee-for-service. So when you're in this straddle or transition zone, which the pandemic has made even worse, revenue drops, you have minimum reward for quality, volume decreases, there's no decisive payment change, pay for volume continues, and that you have to pay for the high cost of IT, and physicians are in disarray, as we saw in the first part of the talk, with so many different arrangements for physician employee. So the shift from value-based care is in danger. ACOs and hospitals are reluctant to put dollars at risk when they're trying to recoup the losses due to COVID. 60% have reported in one survey they want to drop out of risk-based models. And employers don't understand value-based care and are reluctant to force employees into narrow provider networks. This slide comes from Harold Miller of Pittsburgh, who runs the healthcare, the Center for Healthcare Quality and Payment, and is one of the smartest people I know, who talks about why the approach we're using for value-based payments really will never work. If you go over here on the left, you can see there's necessary services in healthcare and there's avoidable spending. So you can see here that there's costs that the providers cannot control and costs the providers can control. We've now had a lot of work on services that reduce this avoidable spending, but holding providers accountable for total cost of care by global capitation doesn't work because the providers can't control what they can't control. So Harold Miller says, look, we know about avoidable spending, chronic disease, preventable chronic conditions, ED visits for exacerbations, hospital admissions and readmissions, preventable progression of disease, unnecessary C-sections, early effective deliveries, progression of disease before diagnosis and cancer. And the problem with the pandemic is we didn't do a lot of people did not get screened, and we're now finding people after the pandemic at higher stages. Use of drugs that are more expensive than necessary, fruitless treatment at the end of life, unnecessary surgery, use of devices that are more expensive than necessary, infections and complications of surgery, and overuse of inpatient rehabilitation. So what Harold Miller says is, let's have all of these ways that we know that we can attack the unavoidable unnecessary services like wellness care and screening, like adequate time for diagnosis of new symptoms, like care management, like birth centers for low-risk pregnancies, like telehealth, like hospital at home for certain serious acute conditions. We now are able to have home IVs, transportation for patients who have difficulty accessing services, and palliative care for serious illness. If you're interested in a way to design value-based payments that actually would work, because they would only hold providers responsible for things that they can control, go to the Center for Healthcare Quality and Payments. It's on the website, and see how Harold Miller has actually designed a way that this could work. Is it being implemented? No, again, because of the gridlock at the federal level and the inability of Congress to pass anything that would be useful for addressing this problem. So let's do the next polling question, Jess.
Sure. So as you listen to these case studies, which factors do you believe created the biggest challenges for these organizations as they tried to drive forward the healthcare revolution? Results are still coming in. I'll give everyone a few more seconds. All right. So Kent or Tracy, do you want to comment on these results at all?
Let me take a whack at this. So 24% said lack of leadership alignment. I think that's certainly true. 37% said lack of knowledge of the intricacies of the healthcare industry. Certainly the healthcare industry is very complex, and there's not one technological app that's going to create so much value that it becomes the Uber for healthcare. Lack of attention to bringing in diverse stakeholders, 11%. Lack of a robust vision, 8%, and inability to overcome obstacles and learn from their mistakes. This is really important. I think healthcare is too risk adverse. And if you look at other industries that have been very successful in uncertain, challenging environments, which we certain face, one of the things that works best is to experiment and try new things and fail quickly and cheaply and then move on. Healthcare has never been very good at that. So Tracy, do you want to make a comment about this?
Well, I'm going to make a comment as we go through the next slide, Ken.
Great.
And we appreciate everybody's input. Thank you so much.
So I want to turn it over to Tracy now, because I don't know anybody that knows more about how to get people and leaders to understand the best way to be successful in a very uncertain, challenging environment. And that's certainly what we face today. So Tracy?
Thank you so much, Kent. I appreciate it. It's a mutual admiration society. Once again, thank you all for joining our webinar today. And Kent, you do have an incredible ability to synthesize an enormous amount of complex data into meaningful information, which we as leadership development consultants and coaches draw upon as we work with our clients across the healthcare industry to build their capacity to lead change. So we want to focus our first slide on some of the leadership lessons that we've learned from the cases that you presented today. And just want to clarify that we were not obviously in the room with these organizations as they attempted to transform healthcare. This said, through our review of the case studies that Kent just presented and our work with other healthcare organizations as they try to transform, we have summarized some of our key takeaways in the form of leadership lessons learned. So from Amazon, let's start there. In the case of Haven, while the vision was well articulated, namely, and you'll remember, simplified, high quality, transparent healthcare at a reasonable cost, there seemed to be a lack of alignment of stakeholders and an inattention to the complex set of boundaries and obstacles that they faced. We learned that leaders need to continually ask who else needs to be in the room, and then integrate those new perspectives to iterate the vision over time. We also learned about the power of resilience with Amazon. Given its failed telehealth and Haven experiences, Amazon now has engaged with the provider sector as it embarks on its acquisition of One Medical. So we strongly believe as a leadership development experts that failure is not inherently negative, but instead an opportunity for shared learning and sense making for future collaborations. Now, in the case of IBM Watson, we learned that clinicians, salespeople, and computer engineers are uncommon bedfellows. It's not enough to just put a group of diverse people in a room together. Instead, time and attention needs to be dedicated for the relationship building and in order to create shared understanding for effective collaborations to flourish. Leaders need to be mindful and humble enough to recognize that what they do not know and be courageous enough to ask questions and challenge assumptions. And in the case of value-based care, which we are still struggling with today, we've deduced that the players were clear on the direction that they were headed, but overestimated how fast they were going to get there. Leaders need to be mindful that there will be unanticipated challenges along the way and be prepared for the transition space, what Kent referred to during his presentation as the curve. We also know that relying on goodwill alone or financial incentives alone isn't enough to drive a change in behavior. An over-reliance on either leads to burnout and turnover, much like what we're seeing today in the industry. So from a macro perspective, there is no holy grail when it comes to healthcare transformation. We can't rely on policy change, big tech, or other factors to swoop in and save healthcare for us. When faced with a Goliath-sized challenge like healthcare transformation, it's important to stay humble and recognize that we are all Davids. Real solutions are not likely to come from one or two leaders or organizations, but instead from the compounding knowledge we all gain over time. Next slide. As the health industry continues to change and evolve under the pressures of disruption, what makes for effective leadership changes along with it. What we'll share in the next few slides is a culmination of our research, working with Kent, working with members of the American Hospital Association during our recent leadership summit there, with healthcare innovators and disruptors like the Walmarts and the Amazons of the world, and health system executives. We are here to answer the question, what will it take from a leadership perspective to transform the US healthcare system? And in doing so, we look to the development of what we call a future-oriented leadership success profile, which is a tool to align industry challenges, much like we learned today with Kent, to leadership requirements. Leadership success profiles are comprised of a number of building blocks, such as industry context and job demands, that ultimately define the dimensions of leadership, competencies, experiences, knowledge, and drivers that are required to drive success. When these profiles are leveraged properly, they support a broad range of talent needs, such as recruitment, assessment, selection, develop, succession, and more. Next slide, please. As an initial step in building a success profile, we look to understand the challenges facing the healthcare industry. So we're going to revisit now Kent's earlier slide from Regina Herzlinger, drawing lessons from our case studies and our research with the AHA on why innovation and transformation is so difficult. This, in summary, creates the context in which leaders are working today. In summary, the industry, as we know, there are new disruptors that are entering the industry in record number. We know that our current financial models are not aligned for value-based caregiving, that new players have an unfair advantage in that they are not held to the same regulatory requirements as the incumbents, that data is complex and the complex nature of healthcare delivery has stalled the promise of tech solutions, and consumer trust, as Kent reviewed, is rapidly declining. Moving to a retail solution where patients are treated like customers faces an uphill battle. So the expectations that are placed on the shoulders of healthcare leaders have never been heavier or more critical. As leadership development experts, we know that the right leadership approach for any given scenario is driven by two things. One, industry context, which we reviewed here, and secondly, strategic priorities, which we'll review on the next slide. Thank you, Ken. The priorities are clear and best summed up by Phoebe Yang, one of a panel of disruptors that we've worked with in the past. She says, quote unquote, it's time for healthcare leaders to dive deep and get real, to break down the challenges to true healthcare transformation. We must address how different players in the industry can collaborate in radically different ways to achieve the affordable, accessible, equitable, and excellent care we all want and know we need. So let's address what we believe are the top 4 strategic priorities driving transformation today. The first is collaboration and building partnerships. As Kent said, the idea that any one leader or one organization can do it alone has proven unrealistic. And that has been demonstrated time and time again, and of course, through the 3 case studies today. Much of what it will take to fix the industry outside the control is outside the control of healthcare organizations and is instead spread among multiple diverse stakeholders. Solutions will require building interdependent partnerships and alignment around broad common goals with others who have a stake in creating health and wellness. Secondly, public engagement and connection. The public's opinion on healthcare issues is defined by personal circumstances and core beliefs about their experience. Most, as Kent described, lack an informed view about the entire system and may therefore be unwilling to advance a comprehensive system overhaul. Therefore, it's our responsibilities as healthcare leaders to do a better job educating citizens about our system of health and the roles of personal responsibility, commercial ops, and government oversight in enhancing public health. Third, improving and enhancing data and tech infrastructure. As we know from today's presentation, the effective deployment of technology within healthcare faces major barriers when it comes to data complexity and requires some fundamental shifts in the way in which we're designing solutions, namely involving people as the center of the tech solution. Armed with this knowledge, we're better positioned to understand the challenge at hand when it comes to developing tools and systems that can assist in the journey toward delivering on key mandates such as health equity and the shift to value-based care. And lastly, workforce support and transformation. As we've learned through our journey toward a value-based care system, leaders will need to be prepared to develop their workforce to deliver care very differently, understand the continuum of care, and reframe their mindset toward whole person care. Further complicating this transformation is the critical need to improve the overall health and well-being of the workforce to reduce burnout, improve retention and recruitment, and respond to an increasingly competitive and complex talent market. So, where does leadership come into play? Kent, next slide, please. Sachin Jain put it best in his Forbes quote, "The more I reflect on it, the intervention that will improve healthcare the most won't be more startups or better healthcare policy. Instead, it will be leaders who fight to make the words in the organization's mission statement really mean something. Leaders who are able to speak beyond platitudes and take action that align with core values. leaders who believe that the pathway to better healthcare means healthier people, which may obviate the need for organizations in its current form. Maybe 2023 will be the year in which we will begin to have this important conversation about what it will really take to move the needle on healthcare transformation. Driving innovation, tackling health equity, and promoting wellness at scale within the United States will require a radically different set of leadership skills than those we've relied on in the past. The natural next step is to turn our attention to what exactly those skills are and how they can be intentionally developed, recruited, and rewarded to move the needle on driving change at scale. So, what will it take? As we reviewed earlier, leadership is driven by 4 key elements: knowledge, experience, competencies, and drivers. So let's tackle each of these. In terms of knowledge, what will leaders need to have deep knowledge of in order to transform healthcare? Clearly, one is of the health ecosystem. Leaders will need to embrace and have knowledge of the vantage points of the various sectors that comprise the health ecosystem, what they value, and what their challenges are. Secondly, culture transformation. To drive change at scale, leaders will need to understand how to engage their organization in full-scale cultural transformation to reimagine their mission, their vision, and their values. And third, tech and data infrastructure. Knowledge of how to systematically structure data to drive valuable insights will be critical to deliver a population health-based strategy and design systems to enhance productivity and enable success amidst workforce challenges. Secondly, in terms of experiences, what experiences are essential? What we've learned is the first is the intersection of traditional medicine and population health management. Healthcare leaders of the future will benefit from experience in both individual patient care delivery and strategies to manage and support the health of the populations that they serve. Secondly, leaders ought not to be entrenched in healthcare. Driving healthcare transformation will require doing things differently than in the past. For this reason, healthcare leaders of the future will benefit from a broader perspective rather than being tied to the way we've always done things. And lastly, experience with partnership development will ensure future healthcare leaders can build partnerships with organizations that have strengths, resources, perspectives, knowledge, networks, and reach to solve shared challenges. Competencies. What leadership characteristics will be required to lead? Optimism is the first one. In the face of obstacles, difficulties, and losses, leaders will need to intentionally choose to see the good within sometimes difficult situations, as well as inspire others to focus on the actions they can take to move toward long-term success. Secondly, resilience and comfort with failure. Approaching change and disruption with a sense of fearlessness and a willingness to embrace failure as an opportunity to learn will be critical for success, as will the ability to spring back from and advocate for ways to overcome adversity. And lastly, collaboration. Taking the time to build relationships with key stakeholders that have a stake in the challenge at hand and work collaboratively to develop a definition of success that incorporates all perspectives. Lastly, we focus on drivers. What will successful leaders be driven by? What will they be passionate about? And there are 3 that we call out. The first is wellness, which is the pursuit of activities, choices, and lifestyles that lead to a state of holistic health for the populations that their organizations serve. Innovation is the second, the implementation of creative ideas to generate value and create improvement, and health equity, meeting communities where they are and allocating resources and opportunities as needed to create equal outcomes for all community members. So in sum, we've learned that to drive innovation, tackle health equity, and promote wellness at scale, the future healthcare leader will be radically different from today's leaders. The creation of this success profile is the first step in creating transformative change. The natural next step is to turn attention to how these leadership behaviors and attributes can be intentionally developed, recruited, and rewarded, as I said before. This will have to be done in order to move the needle on driving change at scale. And our goal as a leadership development firm is to help organizations do just that. Kent, next slide. So it looks like we've covered a great deal today. These are just some of our insights gathered through our research. As an attendee of today's session, you are automatically on our mailing list for the complete success profile and report, which we expect to be released in the next 2 weeks from our work today with the AHA, with various disruptors and innovators within our industry and outside of our industry. So now we're going to open it up to Q&A, and I know that Jess has been monitoring the chat for questions, so I'll turn the mic back over to her to moderate in the time that we have remaining. So thank you all and enjoy the holiday season.
Yes, thank you so much, both Kent and Tracy. That was amazing. And we have some great questions coming in. For those of you in the audience that do have questions, please be sure to click on the Q&A button at the bottom of your screen and submit anything that you'd like to ask our panelists. We do have some great philosophical questions coming in for you both that I'm really excited to share with you. So the first is, what are the points of articulation between healthcare organizations and the larger wielders of power, insurance, regulators, legislators, i.e., how can leaders manage up to the overarching systems to create needed change at the environmental level? Kent, do you want to respond to that one first?
I think there was a technique that I used when I was in Minneapolis called the U technique for coming up with solutions. And at that point, what we were talking about was the health plans thought that there was an overutilization of imaging, CT scans. And what we did was convene patients, radiologists, industry people that made CT scans, the state government, hospitals, and the payers. And the reason it's called U is you really need to get the perspective from each of these different players to come up with a solution. So the health plan CEOs were saying, oh, we're spending too much money on imaging. The radiologist said, there's not a problem, we're making money. The patients said, yeah, but it's expensive, and some studies say that you're causing some cancers with too much radiation. And it wasn't till we had everybody's input that we were able to come up with actually a successful solution that decreased the unnecessary use of CT scans. So this is kind of a specific example of what Harold Miller was talking about, is identifying unnecessary or avoidable care and coming up with a way that you can have the stakeholders be held accountable to make it work better. So it's long, it's difficult work, but it's trying to get the wisdom and accountability of all stakeholders for a problem.
Yeah, I thank you, Ken. And I just might add that I think it's incumbent upon any leader within any one of the sectors that touch upon health and wellness to see themselves as conveners in order to envision something that is new, identify and then align the stakeholders that all play a role within that vision, and then be the convener to manage the relationships and the obstacles that eventually will occur, because when you bring diverse groups together, that is just a natural tendency. And then to continuously act and learn upon or iterate upon the solutions, which is what some of the lessons that we drew out of the case studies that Ken provided today. Without that continuous cycle, without the pre and post-mortems, without the continuous reimagination and the display of resiliency, we're never going to actually be able to move forward. So everybody needs to see their role in creating a new, transformed healthcare system.
Great. Awesome. So another one that came through is, what is the role of insurers as a roadblock in the healthcare revolution?
Well, like everybody, insurers have what they want to decrease cost, and they want to make money. The ACA actually was helpful in this by creating some standards where insurers have to provide so much care. But clearly, I can give you anecdotal personal experiences where insurers have been a roadblock. But also, one of the problems is that we have these insurance companies that have lots and lots of data, and to be able to use that data, I think we need to share that data with all the different stakeholders.
Yeah, I would I would concur, Kent. I think the truth of the matter is, irregardless of which player you are, whether you're an insurance company, a provider group, a policymaker, we all come at the problem from different vantage points. Some of us are for profit, others not for profit. But the idea is to not so much focus on what separates us or what's different about us, but what is similar, so that even if you are partnering with an organization that has a different motivation, profit versus not for profit, you do have to get back to what the mission is. And I think Sachin Jain, if we can just go back to that quote, it really is about identifying how to bring the disparate parts together. And remember that the mission statements of all of these organizations in some way, shape, or form are about improving health and wellness. So you can't do it alone. You've got to figure out ways to do it together. So while one sector may view insurance companies as a thorn in its side, the truth of the matter is you can't actually solve your own problems unless you engage with that quote unquote thorn in a way that's healthy for a collaboration. So better to focus on what can be than what is.
Great, great. So another question for you all. What is your experience in effectively generating positive engagement around a vision, given a legacy of disappointment?
I think that there's lots of excitement. I mean, I'm excited by some of the things that have been done. I wasn't involved, but with the Camden Initiative across the river from Philadelphia, where people were able to identify a lot of overuse of emergency rooms, and some of the creative ways that they looked at that was, putting nurses into the low-income housing to teach people how to use their asthma inhalers. I've been very excited about some of the pilot projects using health coaches who are not really medical professionals, but are people in the community that can engage folks to wellness practices. So I still think you can be optimistic. I think it just takes a tremendous amount of work, and there always will be someone whose interest is blocked by that. I know that sometimes when unions have gotten, I think when IORA first started, some specialists were upset that their referrals went down. So you're always going to have, a push-pull. But again, as Tracy says, if we can go back to the true north, which is, well, what's in the best interest of the patients, at least in my experience, that's useful.
Yeah, and I would say, Jess, we summarized today some of the leadership lessons from the failures that Kent covered today. And I think it is important to recognize and as leaders to continue to work with your teams to embrace the fact that failing fast and failing forward is a strategy, and failure is not inherently negative, right? It is an opportunity to look back, identify what the key learnings are, make some sense, and utilize the learnings as you move forward in future collaborations. And that is a skill set that's required for leaders.
Great. We have some really good questions rolling in. All right, so North Carolina has recently initiated Medicaid managed care. North Carolina has a 4-year glide path to move from fee-for-service payment into in 4 years be 80% value-based payment arrangements with providers. Has this ever been done? And is it realistic? The curve seems like it might take much longer to complete than that 80% goal.
Well, CMS has been pushing all of us to go to value-based payments. I really would refer you to Harold Miller's Center for Healthcare Quality and Payment. He's been a leader in understanding what does work and what doesn't work. And I don't know the details of North Carolina's plans, but I do know that those graphs that I showed you, that if you hold providers accountable for things they can't control, it won't work and they become frustrated. I'm a little bit concerned about, in my anecdotal experience talking to C-suites, is that the pandemic has created some folks that are saying they want to get out of value-based payments, that they just don't want to deal with it anymore. Again, as Tracy said, let's focus on the positive. There have been several organizations that have done quite well with upside and downside risk, but there's been many that haven't done well. It requires physician alignment. It requires really tackling those unnecessary treatments and diagnosis that we're doing now. And that requires some very difficult conversations with people that are making money now on what's been termed unnecessary care.
Great. Okay, so another question here. It seems like a lot of focus has been given to extrinsic motivations, such as pay, to workforce challenges, and not a lot to the intrinsic motivations critical to making roles attractive and staying attractive. Your perspective?
It's a great point. And if you look at the behavioral economics literature, they make this point pretty in an interesting way. I've always been skeptical about pay for performance, and I actually wrote a couple articles about it, because you're right. There's been some studies comparing blood acquisition in the United States versus the UK. And in the UK, they don't pay for blood. In the United States, we do pay for blood. And that creates a different set of motivations. And in the behavioral economics literature, there's some really, really interesting examples. One is from Switzerland, where they had to decide where to put nuclear waste. So they went to these villages and said, we want to put nuclear waste here. The government will give you a bunch of money to allow us to do that. They then increased it, and what they increased the amount of money they were going to give to the villages. And what they found was that the villages were less likely to allow the thing, because they had switched from, like you say, an intrinsic or what's best for the community to saying, oh, this is just about money, then we want more money. Another example from the literature is an Israeli school, which was having a big problem with parents not picking up their kids in time from school. So the board of directors decided to pay to fine people money, shekels, I guess, when you don't pick up your kid from school. And that increased the number of parents that were late, because they said, oh, great, it's not about making the system work better for the whole community. I can just pay the fine. So you're right that having just pay for performance, human beings are not motivated just by money. But if you actually put it in the market perspective, then people are going to want more money. And the last example comes from Dan Ariely, who is a behavioral economist. And he said, next time you go to Thanksgiving dinner at your mother-in-law's house, if you offer to give her $200 because the meal was just as good as the meal you had at the Four Seasons, she's liable to haul off and slug you, because you're not supposed to pay for a Thanksgiving dinner with your mother-in-law. So again, intrinsic versus extrinsic motivation. If you get people thinking about the market, they're going to have one decision. If you get people thinking about what's best for the family or community, they're going to use their intrinsic motivation. to make different decisions.
Yeah, and I would say, Kent, I know we only have a couple minutes left, but I think you've proven through the case studies and as we reviewed the leadership lessons learned that focusing on any one lever in terms of behavior change is not enough. So I would say the extrinsic motivators such as pay, if taken alone, won't do much to change behavior. What leaders need to do is focus on all of the levers, pay being one, but other things as well, well-being, holistic health, providing opportunities around engaging your core motivation to the work that you're doing. And that requires leaders to really do a deeper dive on what it's going to take to motivate, engage, and others to do the work of your organization. And as we know, as leadership development experts, you have to pull upon all of those different triggers. So I'm hopeful that there is movement. We see, at least with our clients, there's movement towards actually engaging and understanding individual motivations so that you can actually get to the intrinsic motivators for teams and to help leaders identify those.
Great. Thank you both so much. Yes, and we are at time. We want to thank everyone for attending today's session, and we hope that this helped to inspire you to want to have the conversations that necessary for healthcare revolution in 2023. As Tracy mentioned, you will be receiving from us a feedback survey shortly, as well as a link to the recording of today's presentation, and within the next 2 weeks, a copy of the complete leadership success profile for the future of healthcare leadership. So thank you all and have a wonderful holiday season.
Thank you. Thank you, Jess. Thank you, Kent.